actually this is the first topic lah, MNT yang kita masukkan dalam MNT 2 ya, for surgical. Previously we combine surgical with burn ya. So this now is only MNT for surgical, so I think it's quite dia tak comprehensive sangat lah, jadi a bit simple lah ya today's punya lecture, because it's surgical. And then actually kalau for surgical ni dia akan pub dalam banyak disiplin lain ya, macam when you learn about liver disease, then there will be surgical in there ya. When you learn about contohnya you belajar pasal pulmonary ke, ataupun you belajar pasal cancer pun ada surgical dalam tu. So surgical dia park dekat banyak ada disiplin lah ya. So surgical juga kita akan touch banyak when you learn about MNT for enteral and parenteral nutrition later ya. So for today is just about overview about the surgical ya, about the metabolic process behind the surgical kan. And then kita just go a little bit about the eras ya, about the protocol of surgical lah, MNT for surgical. So there's nothing really specific on today's lecture ya. Okay, sekejap let me converse. Okay, so this is for introduction yeah. Okay, the introduction is about the pasal the cellular response yes, about cellular response to stress. So actually in order to make a proper plans for the nutritional support for patients that undergoing surgery yeah, so this is why we need to understand, it is essential to understand the basic changes in metabolism that occur as the result of injury. So it can compromise the nutritional status yeah, so we need to also understand the risk factor for the operative complication yeah. So in this slide yeah, it's actually about the metabolic stress yeah. So metabolic stress ni dia adalah direct response kepada any injury yeah. So our body will respond to injury at the cellular level. And the type of cellular response, it depends on the ability of the cell to react, to adapt, and to repair itself after exposure to injury. Yeah? So the cell response here, it may include either the inappropriate accumulation of substances within the cell, changes in size, number or shape, and also inflammatory response. And this is the situation that may occur in critical illness. Therefore, nutrition support, they are also crucial of the component of the critically ill. Okay, so here is the physiological response to starvation. Why we call it starvation suddenly here, yeah? Okay, so malnutrition, it develops when the nutrient supply is inadequate. Yeah? So this is actually during the starvation. Yeah? But it can also develop when the body is unable to utilize nutrients appropriately, or when its nutritional needs are so high that a typical diet cannot meet those demands. Yeah? So during starvation, yeah, the body responds through physiological adaptation, such as lowering the BMR, yeah, so the energy needs will decrease, okay, and the lipolysis will occur, yeah, so this will produce ketone, yeah. So the surgery itself, yeah, it leads to inflammation corresponding with the extent of the surgical trauma and leads to a metabolic stress response. Okay, so here kalau you tengok kat sini dia punya physiological response when the metabolic stress response yeah, so perhaps the body will experience malnutrition yeah, because the nutrient supply is inadequate, or the nutrient supply cannot meet the requirement. Yeah, so our body, it will adapt lah through the physiological adaptation. Yeah. So among the adaptation is lowering the BMR, so the energy needs will decrease. So that's why yeah, bila kita jumpa patient yang undergo metabolic stress yeah, kita kena always reassess, perform nutrition assessment, reassess semula what is dia punya energy requirement. Is it high ataupun is it lower because of this physiological adaptations. Okay. Okay, next is next. Okay. This is the comparison of metabolism during normal nutritional states versus starvation. So you can see that here, during normal nutritional state, the metabolic rate match the current physical activity requirement and body composition. Okay. However, during the starvation, there is decrease in metabolic rate to ensure conservation of energy. Okay. And during normal, carbohydrate and lipid are efficiently metabolized sources of energy that provide about 55 to 85% of energy requirement. However, during starvation, there is a decreased need for glucose utilization, and we utilize lipid as main source of energy. This is the lipolysis. Okay, and then during the normal state, protein is used for maintenance of protein structure and to meet ongoing protein synthesis requirement. But during starvation, the body try to preserve the lean mass and minimizing the protein loss. So this is actually the comparison. What happened to our metabolic process during starvation versus during normal course. Okay. So this figure is summarized the changes in metabolism during starvation. So you can see at this nice figure what is the metabolism response to starvation during short term. So what happened here? So the negative effect of long-term calorie and protein deficit, it has been shown. So success of surgery does not depend exclusively on the technical surgical skill, but also on the metabolic interventional therapy. So we need to take into account the patient ability to carry the metabolic load to provide the appropriate nutritional support. However, when the body is faced with an injury, infection or disease causing metabolic stress, the normal adaptations that protect the body during simple starvation do not occur. So that's the semua pula lah. Okay, so here the physiological response to stress, so by definition it is hypermetabolic. The catabolic response to acute injury or stress and degree of metabolic stress correlates with the seriousness of injury. Okay, so surgery, like any injury, any injury lah, kena terbakar ke kan, accident, it elicits a series of reaction. So when you having surgery, bila ada any trauma, there will be a release of stress hormone. So our body also will respond lah. It will release the inflammatory mediators. Contohnya cytokine. So this cytokine, it will respond to infection and injury. The so-called systemic inflammatory response syndrome, SIRS. So this has a major impact on the metabolism. So syndrome yang dinamakan SIRS ni, dia akan menyebabkan catabolism. Catabolism dekat kita punya glycogen, fat, protein. So kat situ lah akan release glucose, fatty acid, amino acid into the circulation. So that the substrate tu are diverted from their normal purpose of maintaining the peripheral protein to the task of healing and immune response. So senang cerita dah, bila ada injury, body kita akan react lah kan, dia akan merge, divert semua benda, kita punya proses catabolism tu semuanya untuk healing, untuk the wound healing process. So that the consequences of the protein catabolism is the loss of protein, loss of the muscle tissue, which is a short and long-term burden for functional recovery, which is considered the most important target. So in order to spare the protein store, this is why the lipolysis, lipid oxidation, and also decreased glucose oxidation are important survival mechanism. Yeah. So therefore, I think students also know bila kita ada injury, selalunya apa yang kita beri adalah kita berikan high protein intake. Kita kata high protein intake for wound healing, for the recovery process. So this is why, because of the catabolism of protein. So that's why we need to increase protein intake for those undergoing, those experiencing trauma or after surgical. Okay. Okay, this is the physiological response to stress, the clinical manifestation. So the stress response has been described as a progression through 3 phases, which is the ebb phase, the flow phase, and then finally is the recovery phase. Okay. So during the ebb phase, so it is characterized by the reconstruction of body normal tissue perfusion and efforts to protect the homeostasis. So dalam proses ini dia berlaku lebih kurang 2 to 48 hours after the stress, ataupun after the surgery, after the trauma. So dekat sini lah, dekat dalam phase ni ada decrease in total body energy, decrease in urinary nitrogen excretion. So an early increase is detected in endocrine hormones such as the catecholamines and also cortisol. So there is shock resulting in hypovolemia, decreased oxygen, and also decreased cardiac and urinary output. Okay. So during the flow phase pula, flow phase ni macam phase yang apa nama dia, all or nothing reaction. Maksudnya kat sini dah berlaku proses hypermetabolism, catabolism, and autoimmune and hormonal response. Maksudnya kat sini the substrate flow should be high enough for the hit or run reaction. Masa kat sini lah flow phase ni, kita punya badan would try to prevent situation macam bleeding, infection. So kalau response ni severe and occurs and persists for the long time of period, it can lead to the onset of body damage. So this is the flow phase. So dia ada kat sini dia ada hypermetabolism and also catabolism. So the key catabolic elements dekat sini adalah hypermetabolism, dia ada alteration in the skeletal muscle protein, alteration in the liver protein, and also insulin resistance that occurs during flow phase. And then move to the recovery phase, which is the return to anabolism and also normal metabolic rate. Okay. So kenapa kita kena faham benda ni? Okay, so just after the trauma ataupun after surgical, after stress, kita akan observe ada perubahan pada physiological changes lah. Kalau kat sini adalah clinical manifestation of the patient lah. So we must know that is the memang that is the cycle, that is the process yang occur lah. So kalau you nampak dia punya dia punya lab test ke, any indicators tu ada some hair wire, so this is actually might be due to the ebb phase ataupun the flow phase yang itulah. Okay. Okay, so this is again the summary of the metabolic changes in stress and trauma. This is the catabolic insult induced protein energy malnutrition. So this is actually during the fight or flight response. So lepas dia ada trauma, ada surgery kan, it may result in hyperglycemia as well. So hyperglycemia and insulin resistance, it may be controlled by insulin therapy. Also may reduce catabolism and also inflammation. So do not be surprised lah if you can see that after the trauma, after the surgical, patient yang tak ada diabetes pun tiba-tiba dia akan ada hyperglycemia. Because this is actually due to the response to the trauma itself. So during this time, the reliance on protein as source of the glucose. So there will be increased catabolism of skeletal muscle, negative nitrogen balance. So the complications here including immunosuppression, increase the infection rates, delay wound healing, and also increase mortality. So this is what happened here. Apa jadi dekat kita punya liver, kita produce the gluconeogenesis, there will be hormonal response here. sebut dalam gambar ni lah. So that's why nutritional therapy may provide the energy for optimal healing and also recovery. But in the immediate post-operative phase, may only minimal counteract muscle catabolism. Okay, so bila kita nak restore kembali kita punya peripheral protein mass, the body needs to deal with the surgical trauma and possible infection adequately. Okay, so that's why nutritional support, nutrition intake, proper support, and physical exercise as well, they are prerequisite to rebuild the peripheral protein mass or body cell mass. Okay. Astaghfirullahaladzim, sesebut saja ni sesebut. Okay. Okay, here is summarized the metabolic abnormalities that observed in the stress response. This which include increased levels of glucagon, increased level of cortisol, epinephrine, and also norepinephrine. So hypoglycemia and insulin resistance. Okay, increased basal metabolic rate, increased rate of gluconeogenesis, catabolism of skeletal muscle, increased urinary nitrogen excretion, increased synthesis of positive acute phase proteins such as CRP, fibronectin, and ceruloplasmin, and decreased synthesis of negative acute phase protein such as albumin and also pre-albumin. So you know this, this is what happened during the body, metabolic abnormalities, that always observed following the stress response. So the surgeon, they has to balance the extent of the surgery according to the nutritional state, inflammatory activity, and anticipated host response. So we already understand this. This is what happened following any stress response. Okay. So here is just a summary on the pro-inflammatory cytokines and also their metabolic effects. What happened when we observe that this from pro-inflammatory cytokines express their self following the stress. So when there is increase in the TNF alpha, there will be altered. It indicated that there is altered metabolism, and also catabolism of such as amino acid loss, increased hepatic use of amino acid, and also increased lipolysis. And so hypermetabolism, it will indicate a fever. So you know that when there is a NF alpha increase, so that might be indication that the patient will experience all of this. So when there is increase in IL-1, there will be fever. This is due to increase the acute phase protein synthesis. When there's an increase in IL-6, IL-8, IL-12, this is the activation and release of cellular communication of mediators. So the patient might experience fever as well, and interferon, it will damage the respiratory monocyte. This is all we anticipate when we observe an increase in the pro-inflammatory cytokines. Okay. So when there's any stress, any injury, the medical diagnosis and treatment, they will also focusing on treating the underlying injury or illness. Okay, this is actually similar juga dengan kita lah in our nutritional management lah we also always look at the underlying injury, what is actually the underlying disease of the patient. Kita akan fokus on that also to manage our patient. Okay, now just only we look into the MNT for the metabolic stress. So there is a crucial to balance between the prevention of protein energy malnutrition and complications of nutrition support. So I'm talking about nutrition support. What is nutrition support? So tengoklah sama ada kita bagi dia kepada EN ataupun kita bagi dia PN, enteral nutrition, parenteral nutrition, or we just provide them with oral nutrition support. So we must check, we must balance it. Between kita tak nak bagi dia jadi malnourished, tapi we have to also look at the complications. So we have to consider the status prior to illness, level of injury, and also current metabolic changes. Consider status prior to illness. So we need to assess their medical history. We need to assess prior to the surgery what is the pre-operative state, nutritional status of the patient. Kita kena identify lah. Sebelum ni patient tu ada diabetes ke, patient memang ada kidney failure ke, and then is the patient already malnourished prior to the surgery, and then about the level injury. Level of injury is also will determine lah dia punya stress level berapa. This is particularly important when you want to determine the energy requirement for the patient, what is the protein requirement for the patient. And then the current metabolic changes. I already mentioned to you tadi in the earlier lecture, we discussed about what happened during the metabolic changes, what is the flow, what is the phases involved, so we need to we need to take into account the process, the flow and the phases as well. So that's why reassessment, proper follow up, regular follow up to the patient is important. Okay, so among the common nutrition diagnosis during metabolic stress is increased energy expenditure, increased nutrient needs, increased inadequate protein energy intake, altered GI function, and also impact nutrient utilization. Okay. Okay, so nutrition assessment for metabolic stress. So this is the list lah. Apa yang kita kena assess for those with metabolic stress. Basically it's similar. So in medical history, so we assess dia punya apa current medication, what is the previous medical condition or surgery, this is surgery kali ke berapa kan, and then we look into their food and nutrition related history. You see, usually we ask about the ability to chew, use, and feed off dentures. Any swallowing problems? So this determines whether the patient can eat orally or we need to insert any type other type of route of administration for the food. And then we check about if there is the patient experience any nausea, vomiting, constipation, diarrhea. So this is as well as important because it's determined berapa banyak yang nak kita bagi, apa kalau bagi enteral feeding, what kind of solution kan. So any other symptoms that interfering with ability to eat just normal diet and also ability to self-feed. Okay. And then for the anthropometric measurement, we assess the patient height. So usually kalau patient metabolic stress is just terbaring je kan, tak boleh nak bangun je. So you must know how to assess the patient height. Is it using knee height ataupun nak guna arm span, demi arm span ke macam mana kan. So kita buat lah Dulu masa I belajar kan, and masa I practical, sometimes we don't have the equipment kan, kita tak buat pun nak buat measuring arm span adalah practice dietitian I ajar waktu tu. Kita tengok dekat hospital tu punya lantai kan, dia ada satu lantai, dekat lantai tu kan dia ada satu lantai tu berapa kaki kan, so we estimate from that. It's not that tepat lah but there is just for estimation lah, we estimate berapa kaki patient tu kan. But obviously the correct way is you must bring your measuring tape at least for you to measure the patient height. Okay, and then we assess the current weight. So assessment of current weight is depend if the hospital they have measurement yang katil tu, you can assess, you can just kalau tak pun, kalau biasa kau tak dapat weight history pun tak ada we can ask the caretaker about the usual body weight. Sometimes the caretaker pun tak dapat nak jawab usual body weight, so we can just use ideal body weight lah. We look at the patient, kita punya lama-lama you all dah tahu dah, kita tengok patient dah tahu dah patient ni does he look normal body weight or does he look obesity ke, ataupun dia tengok nampak malnourished sangat ke. So we can use the ideal body weight for the patient lah, according to their height. However, if we look at the patient, they look really obesity kan, so we can use adjusted body weight for the patient as well. Okay. And then we can also assess the punya hand grip dynamometer to see the strength. Okay. And then for the physical assessment, we can assess the punya muscle loss. Muscle loss at temples, at the clavicles, at the shoulder, interosseous muscle, at the scapula. So this is actually we can perform SGA, subjective nutrition assessment to this patient. Okay, subcutaneous fat loss, and also fluid accumulation. I believe that you all learned all of this during your nutrition assessment class already. Okay. And then for the biochemical data, medical tests and procedure, we can check their visceral protein assessment, the tube-face protein, hematological assessment, and also other laboratory indicators. Yeah, and the interpretation should take into account the impact of inflammation on these values. Yeah? So when we look into the result, we know lah, we get the idea how severe. Okay, what is the impact of the inflammation? Okay. Stop rising. Okay. So habis nutrition assessment, then we look into the nutrition intervention. Okay. Okay, so for nutrition intervention, I just put here about the enteral and also parenteral nutrition support. I'm not going to teach you about enteral and parenteral nutrition support. It will be another lecture, I think. In your MIT3 kot lagi details, yeah, we teach you about enteral and parenteral nutrition support, yeah. However, we can refer to the 2009 Aspen guideline. I think there's a latest one, yeah, currently about the Aspen guideline. Yeah, this is regarding the route administration, yeah, for enteral and also parenteral nutrition support, yeah. So basically, kalau nak compare antara EN and PN, EN are more cost effective. Yeah, and it can reduce infectious complication and fewer surgical intervention as compared to parenteral nutrition. Yeah, of course lah, kita kalau dietitian, kita nak, kalau boleh kita nak bagi semua oral support je kan, oral nutrition, yeah. But sometimes when the patient really cannot meet the requirement, yeah, so we must suggest them, we must follow the enteral nutrition support lah. Okay. Okay, so macam mana nak bagi energy requirement to the patient? This is among the possible prediction equation that we can use. Yeah, okay. For critically ill patient, yeah. Yeah. So for those with normal BMI, yeah, 20 to 25, we use about 25 to 35 kilocalorie per kg actual body weight. Yeah. And for those BMI more than 30, we can use 22 to 25 kilocalorie per kilogram ideal body weight. Yeah, so you look here, yeah, this is using actual body weight, and also yang ini adalah ideal body weight for those obesity. And this is just a quick method, predictive equation lah. This is for critically ill patient. How we define those patient is critically ill? Yeah, the patient might be in ICU, the patient might be in CCU, and then the disease itself, the patient might be ventilated, sedated, yeah, so that is critically ill patient. Those undergoing major trauma and experience complication, yeah, those patients is in the critically ill in the ICU, yeah. So we can follow this quick method, okay. We can also using Mifflin-Senior equation, yeah, and other Penstead equation and other equation as well lah, depending on the patient itself. Yeah. So kalau patient tu yang ada burn patient, yeah, so they have other specific specific equation as well. Yeah. Okay. Noise. Okay, so the activity factor here, so you can calculate it with activity factor. Yeah? So for out of bed is 1.2, and those who just confined to bed is the activity factor is 1.1. Yeah, and this is the injury factors. Injury, infections, the trauma and head injury, they have different injury factors. Yeah, basically those that involving head injury, the injury factors is higher, so they may require higher energy requirement lah compared to those with surgery yang bukan yang those not involve the head injury. Yeah, so remember kat sini, yeah, injury factor, yeah, and activity factor we might take into account lah bila nak apa formula that need to calculate with self activity factor and injury factor, apa calculation yang tak perlu pun nak take into account the activity factors and injury factors. Yeah, go back and look into your nutrition assessment textbook, nutrition assessment lecture notes. Yeah, macam mana nak pilih energy requirement yang mana, ya, guna formula yang mana untuk determine energy requirement. Yeah. For me myself, I always use quick method lah. Quick method is the easiest way to determine the energy, but of course you must compare with few other formula as well, yeah, for you to get the most justified energy requirement that you can give to the patient. Okay. So here, I also have the protein requirement. Yeah, if you are following RDA, it's actually only 0.8 gram per kilogram protein per day. Yeah, so kalau minor surgery is increased to 1.1, major surgery increased to 1.5. Yeah, tapi kalau orang yang ada burn, yeah, especially kalau dah second degree burn, third degree burn, they require 1.5 to 2 gram per kilogram protein. So the requirement for protein also increase with the severity of the stress as well. Okay. Just a short one slide on there. I think it's about the sepsis, SIRS, MODS. Yeah, SIRS is the systemic inflammatory response. MODS is the multi-organ distress syndrome. Yeah, so this is a definition. The definition here, sepsis is the immunosuppressive response preventing adequate response to infection. Yeah, systemic inflammatory response system is the sepsis without infection, and the multi-organ distress syndrome is the complication of sepsis and SIRS, which will alter function in 2 or more organs. Why I put it here? Because there is a complication, a possible complication of the patient undergoing surgery or those critically ill patients to develop either sepsis, SIRS, or MODS. Yeah, so when our patient dia ada diagnosed with this kind of disease, so the energy requirement and also the protein requirement for this kind of patient is also increased. Okay. Okay. So now only we look into details of the surgery. Okay. So by definition, surgery is the operative procedure that is used to diagnose, repair, or treat an organ or tissue. So we can classify by the seriousness of the procedure. Contohnya sama ada dia major surgery ataupun minor surgery. Yeah, the necessity ni contohnya elective ke emergency season, elective ke emergency surgery. Yeah. And the specific purpose of the surgery. Adakah ia untuk digunakan untuk diagnostic surgery, ya? Or is it palliative surgery, ataupun adakah surgery itu adalah surgery transplant, ya? So we can further classify the surgery, ya, based on this criteria. Okay. So when patient undergoing surgery, there will be nutritional implication, especially if the patients that enter the surgery is malnourished or overnourished. Ya, so bukan malnourished sahaja problem lah, malnourished contohlah ya akan buat problem, tapi overnourished as well. Patient yang overweight, obesity lah ya, obesity, BMI more than 40, BMI 50, BMI 60. So it's really a challenge for the surgeon to perform a surgery to those patients yang BMI ni overnourished sangat. Yeah? Because the surgery itself, it will interrupt the normal nutrition process. Yeah? So the preoperative changes will occur in the weight, albumin, and also CRP. Yeah? So that's why bila kita cakap pasal MNT for surgery, usually kita akan tengoklah MNT pre-surgical and also the post-surgical. Kita kena manage dua-dua lah, because those yang pergi surgery yang memang dah ada banyak complication, ya, dia akan bagi implikasi yang lagi bahaya lah ya kepada surgery tersebut. Ya. Other than the nutritional status, ya, age and also coexisting medical conditions may also play a role. Ya, orang tua ya, ataupun bayi sangat kan, and then the underlying disease, the patient dah memang dah ada chronic diseases ke, ada NCD ke, or patient yang memang cancer ke ya, so it may also be high risk for them as well. Okay. Okay. So the clinical manifestation of the surgery depends on the type of the procedure. Yeah. So traditionally pre-operation kita tak bagi dia makan apa-apa lah sepanjang 12 jam. And patient may have a nasogastric tube. And the anesthesia may result in the post-operative ileus, which is the lack of motility, and the general paralysis of the GI tract. So the diet will resume with bowel sounds and also gas production. So bila sometimes bila apa indication dia, bila patient boleh makan bila dia dah buang angin, baru kita dah buang air besar, okay, baru start makan katanya. So this is the clinical evaluation and what is the traditional method managing surgery patient. Okay, as I mentioned tadi, kita tengok for surgery, we must assess our patient before surgery as well. So we call it as risk assessment before surgery. So it's actually risk assessment according to the pathophysiology, because we know that severe undernutrition it can detrimental to the outcome of the surgery. So malnutrition is generally considered to be associated with starving and also lack of food. So that's why assessing malnutrition is important. Macam kalau orang yang ada malnutrition contohnya dia punya risk untuk wound infection, pneumonia, post-operative bleeding, multi-organ failure, semuanya akan increase when the patient is undernourished ataupun patient in malnutrition, as well as the patient is overnutrition. And all of these complication I sebut tadi, semua tu akan menyebabkan prolonged hospital stay, prolonged recovery period, increased nursing care. It will also increase the medical cost. So that's why kita kalau boleh sekarang ni cepat-cepat nak discharge patient, kan? Okay. So this is the ISPEN guideline guideline in 2009 about the undernutrition. We say that the patient is undernutrition if the BMI is less than 18. Weight loss is 10 to 15, more than 10 to 15 kilogram weight loss more than 10 to 15% within 6 months. Okay. And then serum albumin less than 30 gram, with no evidence of any hepatic or renal dysfunction, and less than 80% of ideal body weight. So this is how they classify the patient as undernutrition here kat sini lah. And then if the patient is overnutrition is when the patient BMI is more than 30 kilogram per meter squared, or the body weight is more than 20% from the ideal body weight. Okay. Okay, so malnutrition it may compound the severity of complications related to the surgical procedure. So a well-nourished patient, they usually tolerates major surgery better than a severely malnourished patient. So malnutrition is associated with a high incidence of operative complications and deaths. So kalau kita tengok lah, pergi prosedur untuk surgery ni bukan saja type of surgery and the necessity of surgery that determine lah whether the surgery is high risk or not, but the condition of the patient. Kalau patient tu sihat, so we say that the patient may tolerate the surgery better as compared to those with malnutrition or overnutrition. Okay. So this is a nutrition assessment. Okay. Okay. So we look into the patient history, into the complaint, into the comorbidities, and also into the social history. Sama lah macam tadi yang kita bincangkan tadi kan, apa yang kita tengok complaint tu ada tak apa-apa dia muntah-muntah ke kan, etc. lah. Into the comorbidities, apa sakit sebelum ni, and also into the social history. Okay. And then we measure dia punya physical examination. This include the anthropometry, and then dia punya NFPE, And then the laboratory investigation, then we also look into the nutrition assessment score. Nutrition assessment score ni kita boleh tengok using nutritional risk score, NRS. This is part of your nutrition assessment class hari ni kan. And we can also use other nutrition assessment tu. The NRS kita guna SGA, kita guna MNA. We can use the nutrient score, apa-apalah assessment that is available at the setting lah. Okay. So, kalau orang ni kita buat nutrition assessment and then we identify that the patient is high risk, perhaps we identify that the patient is severely undernourished, severely ataupun memang overnutrition, or morbid obesity, okay. So, sometimes kalau patient tu will undergo elective surgery, so we can kita akan minta patient tu, kita akan restore balik, kita akan try to restore dia punya nutritional state. There's a dietitian punya role lah contohnya kalau bagi contoh, kalau orang yang yang sangat kurus lah nak pergi operation kan, kalau itu adalah elective operation, perhaps we need to correct the imbalance first. Kita bagilah dulu dia makan, suruh dia makan. If they cannot take orally, we give them nasogastric feeding, at least for them to restore back the metabolic and the nutritional success, because this can allow a successful operation. Ataupun kalau orang yang nak pergi bariatric surgery, bariatric surgery is those for morbid obesity patient kan, sebelum dia pergi surgery tu tak boleh senang-senang terus pergi operate je, the patient dia akan pergi duduk dalam 2 minggu ke, dia kena pergi diet dulu lah, dia need to try to reduce their weight using conventional method first lah, pergi physical activity and change in dietary intake. Then bila dia dah dapat stable, then only they can go for the operation. That is the case for elective surgery lah, and that is the case for emergency surgery, So kita boleh check balik lah apa indikatornya, kita boleh check dia punya, we can reassess on their, we perform on their nutrition assessment, we reassess on their diet, and we can also look into laboratory marker. For example, we always look into the albumin, because albumin ni dia ada it is the strongest predictor for the surgical outcome. Tapi kena ingat juga, kalau tengok kat albumin ni dia lack of specificity, dan sebabkan dia punya half-life dia panjang buat 21 days. It is not really accurate lah with patients liver disease or during the inflammatory response. So one indicator is we can look into the laboratory. Okay. So indication of nutritional support, macam kita tahu patient tu, this is the kind of patient that perhaps we call it macam high risk kat kita lah, when the patient have pre-morbid state. And then we also look at the age of the patient. The elderly, basically kalau adult ni, adult is still usually lah there is a low risk of developing malnutrition as compared to the elderly patient, and then the duration of starvation, dah berapa lama dah dia ada malnourished tu, and then the degree of the insult, and then likelihood of resuming normal intake within a definite period. So this is the indication that this patient might need nutritional support. Okay. So the objective of nutritional support for surgical patient is first we want to provide the nutrition support that is consistent with patient's medical condition. Patient medical condition. Waktu tu apa dia punya diagnosis? So we must give our nutrition support accordingly lah. Okay. Kita bagi contoh semalam ada OSCE kan, OSCE all punya senior. I tengok lebih kurang ada beberapa student lah yang I evaluate masuk OSCE tu, okay? So dalam kes yang kita dapat tu, patient tu actually okay. Kita tengok patient tu dia ada hypertension kan, dia ada hypertension, and patient tu stroke lah, and then the biochemical data everything is normal, tak ada apa-apa masalah pun lah. Tengok albumin normal, liver profile normal kan. And then tapi diet yang tengah dibagi, susu yang dibagi adalah nutrient diabetic. So dalam banyak-banyak student yang I assess tu, tak ada siapa, ada seorang je yang counter. Kenapa pakai nutrient diabetic, kenapa tak pakai formula biasa? So sebenarnya kenapa tu? So that's the thing that I nampak student mungkin tak perasan lah. So I dah cakap kat sini lah ya. So we want to provide nutrient support that consistent with patient's medical condition. Perhaps dan siapa yang tanya this, kenapa dapat nutrient diabetic? So kenapa? Sebab sebelum tu dia hyperglycemic ke kat nutrient diabetic? Sebab sekarang semuanya okey ya. So kita kena tahu benda ni lah ya. So dalam kes macam kes Oski semalam lah, patient tu dah tak ada apa-apa masalah dan gula pun, dan patient is already stable kan ya. So we can just convert to we can just switch back to the normal formula rather than formula for diabetic when the patient doesn't show any diabetes syndrome, diabetes indication kan ya. So we must provide nutrient support consistent with patient's medical condition. Okay, and then we prevent or treat macronutrient and micronutrient deficiency. Can just look macam nak tahu dia ada deficiency macronutrient and micronutrient. Yeah, this is based on the diagnosis. Yeah, based on our nutrition assessment, kita tengok ada ke any micronutrient deficiency. Yeah, we look into dia punya lab test. Perlu ke dia perlu high protein ke ataupun dia perlu specific protein ke kan adakah dia perlukan more zinc ke so we look into that as well and then we provide nutrient compatible with existing metabolism. Look back into the flow, into the phases of metabolic process occurred post surgery dan kita bagi waktu tu dia perlukan high energy ke tak ataupun waktu tu kita perlu lower down dia punya energy requirement and then we manage or avoid complications related to the technique of nutrient delivery. Avoid complication, we manage that kita nak manage, tak nak ada aspiration kan, nak check into that as well and then we improve the patient's outcome such as those related to morbidity, and we want to prevent and minimize the effect of catabolism. Okay. So I hope you clear now so sekarang belum ingat lah, tapi nanti bila nak pergi hospital kan dah terlupa benda-benda ni so I hope it's not so now you learn about this so this is our objective. Kita nak tailor individual specific to the patient's condition masa kita jumpa patient. Okay, so for the nutrition asset therapy post surgery so of course lah, firstly we need to perform the nutrition assessment. What is the energy and also what is the protein requirement is that meet the needs or not kalau ada metabolic stress macam mana so actually for the therapy, nutrition therapy, it should start as the nutritional risk becomes apparent. So kalau kita nampak kita perform tadi awal-awal pre-operative, kita dah tengok dia punya nutritional risk assessment kan. So kalau those yang high risk following post surgery tu kena terus tengok lah, because we need to start the nutrition therapy as soon as possible. So kalau macam kita tak tahu sama ada terapi kita dah berjaya ke tak, of course lah we look into the condition of the patient and then we look into the improvement in the lab profile and then outcome dia, of course the best outcome that we can look into the success or not of our nutrition therapy is we look into the mortality, we look into the morbidity, and then we can refer also to the length of stay. Length of stay ni penting nak tengok berapa lama dia stay dekat hospital, how long the patient stay in the ICU because this is taking into the consideration the economic implications as well. So the improvement of the nutritional status and also the functional status recovery, including the quality of life, are the most important nutritional goals in the post-operative period. Okay, so the nutrition diagnosis during post-surgery can include increased energy expenditure, inadequate beverage intake, increased nutrient needs, alter GI function, and also impact nutrient utilization. Okay. So during the post-surgery, what is the nutrition intervention? So situ first is insulin resistant. Recall back tadi earlier I mentioned about the hypoglycemia following any stress. So insulin resistant, this is actually response kepada starvation. Yeah? This is predominantly caused by the glucose oxidation. Yeah? So some degree of insulin resistance develops after all kinds of surgery, but its severity is related to the magnitude of the operation and also development of complication, for example, sepsis. Yeah, it has implication untuk nutritional management. Yeah, since the patient yang ada insulin resistant ni, dia tak boleh tolerate feeding lah tanpa ada hypoglycemia. Yeah. So kalau patient yang ada insulin resistance, there might be necessity to use insulin to limit the hyperglycemia. So we need to look into our diet as well. So let's say kalau patient experience high insulin resistance, so they experience hyperglycemia, perhaps kalau kita on enteral feeding, that's why sometimes we consider nutrient diabetic kan, formula untuk diabetes lah for this kind of patient. But it's actually the insulin resistance, it is actually the response to the starvation. Okay. And then post-surgery is the progression of post-operative feeding is individualized, and the progress from nil by mouth to solid food as quickly as possible. Maksudnya bila patient nak surgery, so in the traditional way, patient are required to fast. Hari ni nak kena operate, so 12 jam sebelum tu tak boleh makan, tak boleh minum. That is a traditional method lah. However, finding now is say that pre-operative fasting is unnecessary actually in most of the patients. Because patients undergoing surgery who are considered to have no specific risk of aspiration. So dia boleh makan seperti biasa. They can drink clear fluids until 2 hours before the procedure. Solid boleh makan, tak bolehlah puasa 12 jam, 6 jam sebelum the procedure they can eat, they are allowed to eat solid food. And this is actually a strong consensus lah. The agreement is very high lah to support that pre-operative fasting from midnight is unnecessary unless the patient is high risk. Patient yang memang orang tua yang bila makan sikit dia tersedak kan, ada GI problem, so perhaps they cannot eat, they should undergo surgery. Tapi patient yang normal, at least 6 hours before surgery they can still eat solid. So actually pre-operative fasting, longer pre-operative fasting is no longer necessary. Just imagine lah patient kan, orang tua kan yang dah memang tak kisah orang muda pun nak pergi surgery kan, tak boleh makan 12 jam. And then there's many cases suddenly operation postponed, so tak boleh makan lagi banyak hours kan. So just imagine what happens to the body. The body may enter the starvation process, it will disrupt the metabolic process. And then just after surgery pun tak boleh makan lagi. So actually currently there is no the evidence say that the pre-operative fasting is no longer necessary. Okay, so here we look into the nutrient recommendation. Okay, so calorie. So berapa banyak kalori nak bagi? So untuk kalori, requirement kalori, it depends lah. As I mentioned tadi, we can use there's variety of formula that you can use. Kalau dekat dalam ICU apa formula yang biasa, but just a rule of thumb, we look into the calorie tu, we refer to the stress level berapa banyak nak bagi. Those with mild stress and inpatient, we can provide about 25 to 30 kilocal per kilogram per day. Those with moderate stress, in dalam ICU is slightly higher, and those with severe stress, for example burn patient, we give lagi tinggi lah, about 30 to 40 kilocalorie. But it still depends lah. Walaupun kita kata dia moderate stress dalam ICU, but if the patient is it doesn't require really high calories, so we just go to lowest range lah, the 30 kilocal saja. Kalau kita boleh reduce lagi lah to 25, because we know that patient lepas trauma ni, they will experience the metabolic changes kan. So the calorie level we provide them according to their stress level as well. The protein is higher, 1 to 2 gram per kilogram per day. So tengoklah apa requirement the patient lah. Kalau macam burn patient, they are usually very high, we give them up to 2 gram per kilogram. Kalau macam tadi kita bagi severe head injury, ataupun kalau dia moderate stress, we can provide them about 1.5 gram. But protein requirement is higher in patient post-surgical because we need to promote wound healing, and also to meet the requirement of protein. And then for fluid, it is individualized. It's very individualized fluid. We look into the condition of the patient. Apa dia punya medical disease, medical diagnosis as well. Adakah kita perlu restrict dia punya water ke, ataupun we should just normal intake of water. This is individualized, really depends, because kalau dekat ICU kan, kita akan tengok juga dia punya bowel chart, dia punya intake output dia berapa. So kita tempatlah kat situ. Kalau dia punya output is very low, there must be something that we need to assess. Ataupun dia punya output too high ke, rather than dia punya compared to intake ke, so we must check something about that. Okay. Okay, so this is a traditional method. Ini untuk post surgery. So introduction of solid food, it depends on the condition of the GI tract. Oral feeding might be delayed for 24 to 48 hours after the surgery. And they wait for return of bowel sounds, or passage of fetus. Dah angin, baru boleh makan. So you just imagine oral feeding delay for 24 hours. So traditionally pre-operative tak boleh makan 12 jam. And then post-operative delay eating, delay feeding up to 24 hours. So dia dah macam 4 atau 12 jam tak makan lah. And then they start clear fluids when signal of bowel function returns. The rationale for this is because clear liquid diet supply fluid and electrolytes that require minimal digestion and little stimulation of the GI tract. And so clear liquids are intended for short-term use due to inadequacy. So what do you think about this traditional method? You need to consider lah. Kalau orang yang kita bagi just liquid diet kan, kalau even kalau kita bagi liquid diet pun, patient must have adequate swallowing function. Even patient with dysphagia, they often require thicker liquid compared to clear liquid. So you must be specific lah in wanting the liquid diet order for patients with dysphagia. And there is no physiological reason for solid foods not to be introduced as soon as the GI tract is functioning, and a few liquids are being tolerated. And multiple studies, they show that patients actually can be fed a regular solid food diet after surgery without initiation of liquid diet. So actually post-surgery, there's no necessity just to start the patient with liquid diet. If the patient think that they can tolerate solid food, then go for solid food. Try lah makan pelan-pelan. Okay, mula-mula boleh lah suruh minum air pelan-pelan. Okay, tak ada muntah tak. Rasa boleh dia, don't need to fast lah. Boleh lah try makan pelan-pelan, makan bubur sikit. Tengok, okay, tak boleh tolerate tak. Makan roti sikit ke because we don't want patient to prolong fasting lah post-surgery. Okay. So diet advancement, advanced diet to full liquid followed by solid foods depending on patient's tolerance. We consider the patient's disease state and complication that may have come about since surgery. So how about the patients that cannot eat? Memang tak boleh minum, tak boleh makan, tak boleh. So this is where we consider nutrition support. Consider lah whether to start on nasogastric, orogastric. Basically, we start with enteral feeding lah. Ataupun maybe some people they need the parenteral feeding. Okay, ERAS. So we look a bit into the ERAS. What is ERAS? So ERAS is the Enhanced Recovery After Surgery. This is actually a society, ada ke society lah. The protocol are multimodal peri-operative care pathway designed to achieve early recovery after surgical procedures by maintaining pre-operative organ function and reducing the profound stress following surgery. So this is actually a society that has published a consensus statement and guidelines. This is actually a powerful tool that has been implemented across hospital and healthcare system worldwide. The purpose is to improve the quality of surgical care. So sebenarnya ERAS ni dia ditubuhkan oleh surgeon lah, surgeon dekat western countries ada, based on the principle that actions undertaking to modulate the post-operative stress. It can improve the recovery after surgery. So bila kita implement ERAS ni, studies shown that early mobilization, early reintroduction of nutrition, and rapid discharge are feasible and beneficial for a large number of post-operative patients. So kita dietitian dalam bidang ni, we are really looking forward to follow ERAS lah, because ada dalam ERAS ni, one of the component is early reintroduction of nutrition. Maksudnya tak payah delay feeding up to 3 hari, 2-3 hari baru start feeding after surgery. This is the diagram of ERAS lah. So kau tengok dalam ERAS ni, ni adalah pre-operative, and this is post-operative, this is intra-operative lah. So dekat sini ERAS ni, this is ada pre-admission counselling, fluid and carbohydrate loading, and no prolonged fasting. So this is actually related to us lah, fluid and carbohydrate loading. Apa maksudnya? Maksudnya sebelum dia pergi surgery, about 12 hours, 6 hours tu kan, beberapa hari sebelum surgery juga, untuk fluid and carbohydrate loading ni is like few days before the surgery, one night to take the surgery, kita bagi dia makan solid yang include carbohydrate. And then tapi bukanlah binge, maksudnya ada makanan tu ada unsur carbohydrate, the patient should take that. And no prolonged fasting, which means that 6 hours prior to the surgery, patient can eat a solid, but this is still depends on the patient. Jadi kita tak boleh buat benda ni lah. This is actually recommended by the surgeon lah. Tapi this is the principle of the ERAS, the pre-operative. No selective bowel preparation, antibiotic prophylaxis, thrombophilaxis, and also no medication, no pre-medication. This is the protocol pre-operative. And then the intraoperative, this is the intraoperative. And then the post-operative, apa yang terlibat kat kita ni, actually they suggest on no nasogastric tubes. So no nasogastric tubes. So kalau boleh kita tak ada dia pergi enteral feeding lah, we want them to start oral intake. So few hours after the surgery, bila patient dah sedar, they can start eating. They can start with try minum air, try minum chicken water, and then kalau boleh minum terus makan solid food. This is actually what they suggest lah. Tapi yelah, sometimes patients sendiri tak larat nak makan, betul-betul after surgery dia just tak larat, tak boleh nak bangun kan. So slow-slow lah makan sikit-sikit, makan soft diet sikit-sikit ke apa yang patient boleh tolerate. But if the patient cannot eat, barulah kita kena insert juga nasogastric tube tu. And prevention of nausea and vomiting. Ini bukannya kita this is a multidisciplinary approach lah. Doktor mungkin akan bagi some medication or tips lah to prevent the nausea, and then kita boleh plan what kind of food that is suitable for post-operative patient that can prevent the occurrence of nausea and vomiting. Then apa lagi yang berkaitan dengan kita here is early oral nutrition. And then early mobilization, we tak nak baring terlalu lama, so this is actually apa post operative lah, okay. So I give you a situation lah, paling senang situation surgical ni, simply imagine contoh Caesar, post cesarean, ibu-ibu yang lepas bersalin secara pembedahan, I bersalin pun tak dalam last I bersalin operate 7 years ago lah, I bersalin C-section, elective C-section, so I experienced this 12 hours prior to surgery dah tak boleh makan. I was scheduled for operation, I tak silap I pagi lah, pukul 8 pagi macam tu, pukul 8 malam dah tak boleh makan. So you know that ibu mengandung dia hungry, cannot eat. Okay, I experienced that lah, and then after the surgery pun tak diberi makan lagi lah, and you know I feel really hungry lah, and I think that this is tak sepatutnya berlaku lah, but then after I dah sedar kan, I just ask the doctor lah, can I eat? Dia kata okay, you can try to eat lah, okay. Try minum air, okay, minum air kosong sikit, okay, and then I buat Milo, okay, then terus start makan bubur, and luckily it's okay for me, but I notice myself lah, sendiri nampak ada patient kat depan tu sama juga post cesarean, dia cuba makan jugalah kan, dia cuba makan, tapi lepas dia try je makan sikit terus muntah banyak. Tak tahu apa yang dia muntah lah, sebab sebelum tu pun dah fasting kan, terus keluar semua. Dia try makan lagi sekali, muntah lagi, so this is actually why sebelum dia traditional method kita tak bagi dia makan, sebab you know there's a risk lah untuk nausea and vomiting kan, so it really depends on the patient lah, so kalau patient tu boleh tolerate, memang kita minta dia untuk early oral nutrition, start makan after you eat, just few hours after the surgery, just eat, because this is to restore yourself, and then early mobilization, those patient yang lepas operate, macam kes tadi lepas C-section kan, boleh berjalan, bukannya kena baring saja, you must walk, because it can improve your blood circulation, it can actually, bukannya lepas rehat tu baring je untuk improve the wound healing, actually lebih banyak you gerak tu, it can improve. Tapi bergerak hati-hati lah, bukan suruh berlari kan, gerak hati-hati, because it can improve your the circulation, and actually it can improve the quality of life as well. Baring je pun sakit juga kan, so this is actually the protocol of IRAS lah, yang tadi tu cerita je lah, yang related to us is actually the pre-operative is for the carbohydrate loading, and also no prolonged fasting, and the post-operative is the early oral nutrition, and the prevention of the nausea and vomiting, and also no NGQ, so we are happy with this protocol of IRAS, because it's really support us lah as a dietitian kan, okay. Here comes towards the end. The critical point is the combined impact of metabolic alteration that occur in stress and bed rest can lead to rapid and severe depletion of the body mass. So nutrition support cannot fully prevent or reverse the metabolic alteration and disruption in body composition associated with critical illness. However, nutrition support likely ameliorates the rate of net protein catabolism. Clinical judgment is paramount in making decision about the need to initiate nutrition support. But this is actually lebih kepada surgeon, anesthesis, and the medical doctors lah. They must have the critical judgment lah when to start nutrition support or not. So our rule kan, kalau kita tak nak patient on nutrition support lah, so we need to really consult patient, the caretaker to try on solid food, tapi kalau dia memang tak boleh solid food, usually they will start on nutrition support lah, okay. So for patients who will require enteral nutrition, it should begin as soon as hemodynamic stability is achieved, okay. And enteral nutrition is preferred because of its role in maintaining gut integrity and also immunity. Okay. So critically ill patients who are injured, septic or bedridden cannot be expected to gain weight LBM or strength until the hypermetabolism resolve, and physical therapy, exercise and rehabilitation begin. Okay, this is the thing yang nak cakap lah ya. So bila kita dapat patient critically ill, post surgery yang malnourished sebelum tu ya. So our aim is just for the patient to receive adequate nutrition support. Bukan kita punya aim bukannya nak increase dia punya body weight ya. Ya. Tak boleh masuk dalam our goal, our objective of MNTs tu increase the weight of the patient. No ya. So that is our goal. Kalau ada improvement in body weight, that's good lah. But then body weight increase ni bukannya boleh increase terus kan dalam patient yang critically ill macam tu ya. We afraid lah kalau sudden weight gain tu is related to the accumulation of body fluid ke etc. Ya. So that is not our main objective lah ya. Our objective is actually to provide sufficient energy for the patient lah to untuk dia punya keadaan waktu tu lah ya, for brain healing ya, to for the infection ke ya, just to meet the sufficient requirement ya. Bukannya kita punya matlamat kita untuk menaikkan berat badan patient. Although if the patient yang malnourished to gain weight is something that we are looking for. Okay, that's all. Okay, so macam cakap ni lah, untuk lecture surgical ni it's not really specific because surgery ni is in many other discipline of MNT as well ya. So kalau tapi apa yang I ajar tu adalah what is the basic lah ya, apa fundamental that you need to know about surgery ya. So we know that those undergoing surgery they will undergo metabolic stress ya, the stress response ya. So there will be a physiological changes in the body that you need to take into account when you plan for the nutritional requirement. Yeah? And basically, generally, the protein requirement increase because due to the stress, yeah, and also due to the injury response. Yeah? And energy requirement is much or less similar with prior to surgery ya, but however it increase for patient with yang severely stress ataupun severely ada major surgery ya, ataupun ada head injury will increase ya, tapi tak lebih kurang sama lah. And what you want to do is you want to provide adequate nutrition support to the patient. Those who cannot eat orally go to nutrition support. Yeah, nutrition support you will learn it later lah during MNT 3 I think. Okay. Ada apa soalan tak pasal surgery?
Saya ada soalan doktor. Tadi doktor ada bagi tahu yang new finding kata sebelum puasa sebelum surgery tu pun macam tak perlu pun sebenarnya, ada yang finding kata begitu. Tapi macam kita tahulah kan, mana-mana surgery yang involve anesthesia kita suruh fast sebab nak avoid aspiration, sebab nanti makanan tu akan go to windpipes hence aspiration lah. So macam mana kalau yang tak puasa ni nak prevent aspiration ni doktor?
Itulah dalam banyak study yang dah cakap ya, there is no need to avoid until 12 hours. By 2 hours before surgery pun dia boleh minum clear liquid. How to kita tak boleh cakap nak prevent lah. So that's why kalau orang yang memang ada high risk of aspiration ya, memang dia perlu follow lah that 12 hours of meal by mouth tu kan, tak boleh makan, tak boleh minum langsung. Tapi banyak study dah prove yang actually there is no risk of expiration pun following the anesthesia. Ya, maksudnya 2 hours before tu still boleh minum. Bukanlah minum banyak, just minum untuk hilangkan you punya haus. There's many study that prove that. Ya, tapi of course lah, this is not our judgment lah to let the patient drink or not. Yeah, it really depends on the anesthetist and the doctor lah. Kalau doktor kata anesthetist tu memang from their experience, apa yang dia tengok memang patient tak ada yang experience kan, so they will allow the patient to drink. But so far study already say that there is no necessity for pre-operative fasting. Yeah, and it's actually a good great one evidence lah. Yeah. So kalau baca evidence kata dah tak perlu dah. Kita nak cakap nak macam mana cara nak prevent pun tak boleh juga. It's not us kan yang buat prosedur tu kan. So itulah, study cakap tak perlu, tapi I know that practicality in Malaysia, realitinya kebanyakannya masih kena fasting, because perhaps that our hospital they observe lagi banyak case yang expiration kan, compared to study yang published kan. I'm not sure about that lah, but in the realitinya memang kita kebanyakannya still fasting. Okay.
Thank you, Doktor.
Okay, ada apa-apa lagi soalan tak? Okay, kau tak ada soalan?
Doktor nak tanya.
Ya?
Tadi doktor ada mention masa nutrition intervention untuk post surgery kan, kita kena take into consideration insulin resistant kan. Jadi kiranya kita kena, kalau macam dalam diet plan tu, kita kena kurangkan source daripada karbohidrat ke?
Betul.
Taklah guna dengan protein.
Yes, we need to take into account the simple sugar lah basically. Carbohydrate, simple carbohydrate tu actually for diabetic also dia punya carbohydrate intake pun about similar to normal diet kan, cuma they cut down their simple sugar intake kan. Sama lah juga macam yang ada experience hyperglycemia. Tapi kalau tengok hyperglycemia ni, this is a metabolic process and it will change once the metabolic response back to normal ya, and the patient will be on insulin as well ya. So tapi kalau kita dia oral diet, kita kena take into account that ya, dia punya exchange, dia punya simple sugar and then the exchange of carbohydrate dengan timing of intake tu pun kena jaga. Dan kebiasaannya patient ni yang macam ni, most of the case jugalah tengok patient is on tube feeding. So bila patient on tube feeding itu yang jadi case, kadang kita bagi dia nutrient diabetic, formula diabetic diet, formula untuk diabetic tu. So once dia dah return to normal state, dia tak ada hyperglycemia, then we change to standard formula lah. Dia boleh back kepada normal diet lah. Tapi bila dia dah hyperglycemia tu, we look into dia punya exchange size, carbohydrate, simple sugar, semua tu kita tengok lah.
Alright, faham doktor. Jadi insulin resistant tu dia temporary je kan doktor?
Most of the time is temporary. Dia beberapa hari, beberapa minggu sampai dia metabolic state dia kembali stable. Most of the time lah.
Okay, alright. Thank you doktor.
Okay. Okay. Sebelum tahu apa-apa soalan lagi, mungkin kita nak discuss kejap tarikh test. You have one test with me. Batch ni ada final exam tak? Tak ada kan? Ada tak? This batch? Part 4.
Tak ada
final exam ya. So our test, because this week is the last week for lecture, so next week I bagi kita ada study leave. So can we do test? It will be online test during minggu pertama final exam tu, antara 7 ke 11. Will be okay for you? It will be online test, okay? Do you have any other test yang dah schedule on that day, on that week?
So far tak ada doktor.
So far tak ada. Okay, good. So I will schedule your test during that week lah ya. So test only will cover my topics ya. Format I belum finalize lagi, but it will only cover my topic lah ya. So next week you have 1 week lah untuk rest and then to do your revision ya. I will let you know about the format and also the duration of the test ya, bila I nak open test ya. The time inform dekat Nick next week lah ya. Ataupun I akan announce the new feature. So we will conduct our test during that week ya. Test and AD605. Okay. So itu saja. So any other question regarding this topic, today's topic? Oh, I selalu terlupa. Ada student yang dah minta I upload recording. I will upload it later ya. Saya asyik terlupa saja. I upload semua recording for you to do revision. Okay. Is there any other question?
Doktor
can
nak
we-
tanya.
Yeah.
Kalau contohnya kan untuk yang act phase, flow phase kan, dengan recover phase tu, dia punya nutrition needs tu memang berbeza
It doesn't really difference pun. It's about the same sahaja. Kalau nutrient tak ada beza sangat. Cuma sometimes ya, you akan nampak dia punya laboratory parameters tu dia dia ada yang abnormal. So that is why lah, that's explained because of the different phases following the metabolic response tu. Tapi biasanya dietitian ni betul-betul following the stress. So dia belum jumpa lagi dengan patient. Unless kita duduk dekat hospital yang dia punya anesthesis surgeon tu sangat appreciate dietitian. I don't say that surgeon tak appreciate dietitian, but in some ICU they have their own team yang manage nutrition kan. Bila feeding dah stabilize baru dipanggil dietitian So biasanya itulah yang I nampak So usually lah kita tak involve sangat masa during the critical phase following the trauma tu. Tapi kalau untuk pengetahuan lah daripada segi in terms of nutrition, energy requirement, protein requirement tu tak banyak sangat beza. Dia lebih kurang sahaja. Sebab tu jugalah ada setengah ICU awal-awal lepas tu dia tak panggil pun dietitians because they have their standard regime untuk patient yang following major surgery macam ni. Cuma kita kena faham lah kalau you tengok dekat kenapa bacaan lab dia macam ni, bacaan darah dia macam ni, apa jadi dengan dia demam ke apa, kenapa. This is perhaps due to the response following the surgery. Different phases.
Faham? Alright, thank you, Doktor.